Position, I can say something.
People want to do the well there,
I know, but they.
but the policy, legislation,
Yeah.
political base, these things are basically hurdles.
We just started market, yeah. Gets it on the agenda, and substantially just get
And
there.
the second thing, the government is want to take all things in their own hand. They are not choosing
You went to Hopkins?
no.
call. With the consent of the panelists, I would like to start by presenting my current study, which I conducted and tried to evaluate the role and the influence of mother-in-laws on young married couples' family planning decision in Karachi and Hyderabad division. Let me just tell you the background first that we are working on a TCI platform. It's a global platform where we support the local government to scale up the high impact interventions for family planning. And this is to facilitate the self-reliance and sustainability while achieving the impact. And this tool supports the FP 2030 commitment. So we are currently working in 15 cities, 15 districts of Pakistan, which you can show here. So we are working on the high impact interventions like community health workers, facility makeover, family health days, satellite camps, through which we have engaged more than 5,000 community health workers. We have done the makeover of more than 66 facilities in Sindh and Punjab and Islamabad. And through the family health days, we have entertained more than 6 lakhs FP clientele through our family health days, and more than 4 lakhs FP clients were entertained in the satellite camps. So in urban South Asia slum, uptake of family planning is often dependent on the family members, especially the role of mother-in-laws and their husbands is very crucial when we talk about Pakistan's cultural norm and the dominance, male dominance, and the mother-in-law's dominance society we live in. So an understanding of these dynamics becomes very imperative for culturally appropriate FP interventions to be designed. And the objective of this study is to qualitatively evaluate and explore the role and influence of mother-in-laws on family planning decisions of young couples in urban slums of Karachi and Hyderabad in order to identify that what were those barriers and facilitators to contraceptive uptake. Methods we use, so it was a convergent mixed method study, which we have done it in January to June 2025, and we have integrated qualitative and quantitative components. So this design was actually adopted for the in-depth understanding of the social dynamics and was centralized to research questions where quantitative patterns has supported the study, but it did not drive the conclusions. So the qualitative results have shown the immense impact. In Karachi, we have taken the 120 young couples. That means that 240 individuals took part in this survey. Whereas in Hyderabad, we have taken 100 young couples. And each couple included a young married woman, which was in the range of 18 to 30 years, and her husband. Mother-in-laws of all participating women, they were interviewed, and they were 220 frequency. So 660 individuals participated in the study. Whereas the in-depth interviews idea was concerned, we tried to explore the family planning knowledge and their perceptions, also the household power dynamics, the decision-making roles of that family, and what were those health beliefs and the religious beliefs, how this was intervened, and their experiences with the contraceptives. So the idea is focus group discussions and the questions which were structurally designed for the quantitative module. So it was regarding the contraceptive use and the perceived mother-in-law influence, decision-making autonomy indicators, and their exposure to FP counseling, and what were those beliefs about the side effects and the religious permissibility. So we have done the data analysis, and for the qualitative, we tried to evaluate the themes, what were those themes corrupted, and using the in vivo, we have done the analysis. Let's just discuss the quantitative results first. The qualitative ones are more very interesting, but the stats we will discuss first in the quantitative one, and I'll come to the qualitative ones later. So, whereas the quantitative result states that the prevalence of mother-in-law influence on contraceptive decisions, so it was 68% in Karachi and 72% in Hyderabad. And whereas when we see the modern family planning used by the level of mother-in-law influence, so it was about 42% in Karachi, where they have high influence, and where the influence was low, so the contraceptive use was higher. So, inversely proportional it was when we tried to evaluate this influence, 76%. So, whereas in Hyderabad, where the influence was higher, the contraceptive use was 38%, whereas the influence was lower, it was a similar percentage, that was 70% in Hyderabad. So there were common misconceptions among the mother-in-laws, and those common misconceptions were regarding religious beliefs. The second thing was the infertility. They have the thought that contraceptive can cause the infertility later in the later stages. Contraceptives weaken the woman, and also the FP increases the marital conflict. So these were the percentages in which the misconceptions were find out and evaluated. So preferred interventions for improving FP uptake, like counseling sessions have worked 75% of the individuals with where we have conducted this survey. Community workshops has shown 68% of the results. Sharing positive FP experiences from the early adopters, so that was 71%. And couple focused counseling has resulted us in 49%. Let's come to the interesting part, which were the qualitative results. So overall, three themes which were identified through in vivo. And the very first theme, it was about the mother-in-law's authority over the household power structures. So and the sub themes were like they were expecting early childhood, early childbearing from their daughter-in-law. So that was the one theme. And preference for the sons. I was just present in the previous session before the team, and I was I observed the same thing which the girl from the Quetta has asked the same question, that the preferences for sons, and this was the sub theme which I have even find out through my analysis as well. And last, the mother-in-law approval required for any FP use. So that was the one theme which we observed. And the other mother-in-law from Karachi, she quoted that a newly married girl should not think about spacing. It's not her place to decide. So this is how the perceptions are, unfortunately, in our society. And a very young woman in Hyderabad, she said that I cannot start anything without telling my mother-in-law. She will be very upset to hear this. The second theme was about the misconceptions and moral beliefs around the contraception. So this was another highlighted theme which I find out. So it was about the religious disapproval, which we have heard most of the time, that it's using these method angers God, and children are his decision. So this is the major phenomena. This is the major frequent hearing statements that you get it from the society. And also a mother-in-law from Karachi, she said that my neighbor become barren after injections. I don't want that for my own daughter-in-law. So you see how the fear of fertility is there in our society. And also the health myths, it's about the future complications, that if my daughter-in-law will adopt any method, she'll probably face the future complications, or it can cause cancer, weaknesses, etc. And last, it was about the emerging facilitators for FP acceptance. So the first two themes were little disappointing to know the cruel reality or perspectives of the people that resides in Pakistan, and especially in Sindh. But this theme has given me the hope that at least the influence of trusted early adopters like women who have adopted, who are young. So they are, portraying a good image to adopt the family planning methods for other young girls as well, right? Also, the religious clarification is a turning point. We often realize that now the awareness is going on. The education sessions are being delivered by the Islamic scholars, especially the imams of the masjid are playing the active role. And they are now supporting the FP methods. And also the desire for economic stability and reduced household burden. Again, the inflation rate is very high, and since we have moved from developing countries to the underdeveloped countries, and inflation is the very one component that it convinces the men of the society that if we have lesser children, so we have lesser burden on our economic stability. So a very young woman from Karachi, she stated that when a lady from our lane told her story, so my mother-in-law, she listened, she respects her. I mean, she is getting convinced when others are telling that you can have the FP choices as well. And husband from Hyderabad, he said that if the Maulvi explains it, people will believe. So this is the reality. When the influencer says that, when the educationists say that, when the imams of the masjid speaks about it, so everybody believes. So my recommendations after this pilot, after this study. So mother-in-law is focused on FP education sessions because by addressing two main misconceptions, that was the religious prohibition and infertility fears, we can move further. Peer education model for mother-in-laws. Also the family level joint counseling that involves the husband, wife, and the mother-in-laws. So that can also work, and that can be delivered by the community health workers to, clarify the roles and reduce the resistance for FP. Another recommendation, which is an important component, religious leader engagement, because community sessions explaining Islamic guidance on birth spacing, that plays a very mandatory and very crucial role. And these addresses concerns reported by 54% of the mother-in-laws. And use social learning through real life stories, because we live in a social media era, and where we see that the successful stories, even we are convinced with the idea, right? So short videos or in-person sharing by the FP early adopters from the same slums, and we can highlight the health benefits and reduce financial burden. So these are a few recommendations after my study. And conclusion is just this, that urban slums of Karachi and Hyderabad, mother-in-laws have a considerable impact on the family planning choices of young married couples, but modern contraceptive use and contraceptive friendly households can be improved through culturally tailored education, community workshops, and sharing of success stories aimed at engaging mother-in-laws. Thank you.
Thank you.
Questions?
I think we will, we will compile all the presentation first, and then we'll go for question answer. Dr. Tara, thank you very much for keeping the time. You were 2 minutes early in finishing your presentation, so thank you. I now invite Dr. Salma Zahir, the lecturer in Higher Education Department, KT Peshawar, to present her paper on examining women's reproductive agency within gender norms and power dynamics in heaven from health. And you have also.
Good morning. Today I'm presenting examining women reproductive agency with the gender norms and power dynamic in book on Hawa, but I have taken my own district because I belong from district Savadi. So first one, I will introduce what is the women reproductive agency, what is gender norms, and what is power dynamics. Basically, refer to the woman's ability to make autonomous decision about her reproductive health is related to the woman reproductive agency. That is the pregnancy, the childbirth, and choices about the contraception. while the gender norms refer to the gender-based role, behavior, expectations, and society considered for individual. For example, restriction the female freedom and promoting the more male authority in reproductive health and family planning, especially in others. While the power dynamic refer to the distribution of the power that affect the woman's ability to make independent decisions about their reproductive health. So this is the statement of the problem. Women reproductive agency in the districts Samavi of KP is significantly influenced by the traditional gender norms and power dynamics that limited their autonomy in making reproductive health decisions. Regardless of national and international commitment to the gender equality and reproductive rights, the women in district Samavi of KP continue to face the cultural and economic barriers that restrict their decision-making power about the reproductive agency. So this is the significance of the problem. The first one, it increased awareness in women about their reproductive rights and their choices. The second one, it provided the better policies for a woman's health and awareness of how the gender norm and the power dynamic affect the reproductive agency. The third one, it highlighted the barrier women face in a reproductive health. And the last one, it helped to promote the gender equality and reproductive rights in a conservative society, especially in a district. This is the research question. My study based on a different research question. The first one, how much do women understand regarding their reproductive choices? The second was, does the gender norms affect the women reproductive choices? And the third one, how do power dynamics affect the women reproductive choices? What these factors affect the women decisions regarding family planning and contraception uses? And another one, what are the common problems encountered by the woman during the pregnancy and the childbirth? And the last one, what are the most effective techniques for enhancing the woman reproductive agency? So on the basis of my research question, I have conducted some research objectives, which is related to the research questions. The next one, this is the research methodology. In the method, I have used the qualitative methods in which we have taken some sample size. The sample size is my district Samavi, in which I have taken the 4 Tehsil, Topi, Lahore, and Reserve. And the next sample size, which was based on educated and uneducated married women, the age 15 to 49. Further, the different responses of the women are classified according to the different age of groups. And data collection method based on 3 methods. The first one, I have conducted the survey. The second one is interview, and the third one is a focus group in which educated and uneducated married women. So the main analysis is depend on my research questions and research objectives. On the basis of the first research question and research objectives, I have conducted a survey in which we have asked how much women understand regarding their reproductive rights and reproductive health care. So this is the different percentages according to the different level of understanding. The first one, only 25% of the females are have keep a high understanding. The reason is that because they have higher level of education, they belong to the urban residency, higher awareness about the reproductive rights, and then no restriction of the barrier. Only 35% of women have a moderate understanding about the women's reproductive rights and healthcare because they have a more intermediate level of education, small awareness, limited cultural barriers, and the 30% of women have a low understanding because they have low level of education, rural residency, lack of awareness, and cultural barriers. The next one, the next finding is totally based on my second research question and the second objectives, in which does gender norms affect the women's reproductive choices in a KP? So yes, definitely gender norms affect the women's reproductive choices of the KP. So these are the different responded of the women, in which 65% of women says yes, 65% of women agree yes, the husband decided the number of the children, especially in a conservative society, conservative region, like for example in my district, Sawabi. And 75% of agree yes, the woman require the permission to access the reproductive health care. And the 60% of women agree yes, in this region, the contraception uses is considered taboo, and only 30% of women are taking involved in reproductive decision making. The next one finding is based on my third research question. how to power dynamic affect the woman reproductive choices. So these are the different effects in which the husband decided the family sizes. 75% says yes, we have need a permission to from your husband or from me to visit the reproductive health center. 40% of women says yes, this discussion for the using contraception. Only 40% of women discuss only the contraception openly, because showing a reproductive discussion are not possible due to the male dominance. 65% of women state yes, the financial control by the male. In this region, the female are totally dependent on the finance of the male. So it's mean it affect the woman's ability to make independent healthcare decision. And 28% of women reported the mutual decision making, highlighting a lack of partnership in the household reproductive decision. The next one, what factor effects? So these are the different effects which these are the different. Sorry to say, G. What factors affect the woman decision regarding the family planning and contraception uses? So these are the different factors which also affect the woman decision regarding the family planning and contraception uses. The first one, the husband approval. The second one is the religious belief, access to the health services, education level is must for women, and family and social pressure, economic constraint, and awareness from the health worker, social media. So these are the different percentages. Yes, 72% of women says the husband approval. 60% of belief, yes, the religious belief is also matter. So the next one, what are the common problem encountered by the woman during the pregnancy and the childbirth? So these are the different common problem in district Savali, which are encountered by the women during the pregnancy and the childbirth, lack of skilled birth attendant. This is the main problem. The next one is a poor pregnancy care. Let's suppose, for example, 65% of women affected by the poor pregnancy care. 60% of women deprived from the receiving time and satisfactory care due to the financial constraint, and 55% of women deprived from the transportation issue, especially in these regions, and 50% of maternal health care of women affected by the traditional belief and the social norm, and 40% of women is demoted by domestic violence and the lack of family support during the pregnancy, and 35% of women pregnancy suffer from the poor nutrition. So the last one is which effective techniques should be necessary to enhance the woman reproductive agency in favor of Kanakawa. So these are the effective techniques which if we can use in these regions, so definitely the woman reproductive agency in favor of Kanakawa, especially in this Sawabi, can be enhanced. So community health education should be hona chahiye. Women support program, involvement of the religious and community leaders, the mass media campaign, male environment and reproductive dialogues. Or the last one is legal and policy reform. So this is the final conclusion. The study has critically examined the relationship between the gender norms, power dynamic, and women reproductive agency in district Sawabi of Khyber Pakhtunkhwa. The findings reveal that the women reproductive decision making remains significantly affected by the male authorities, social and cultural expectation, and unequal household power dynamic. These factors collectively restrict the woman autonomy over their reproductive rights, including the decision about the contraception, family planning, and maternal health. So the study also highlighted the limited access to the education and lower awareness of the reproductive right that constrain the woman's ability to make reproductive choices. Male dominance in household decision making and the lack of the spousal communication were found to be a major barrier to the reproductive agency. In contrast, women with a higher education background, the financial independence and support a male partner show a greater confidence and participation in a fertility-related diseases. So finally, the enhancement of the women reproductive agency require a multi-dimensional approach that include empower the female education, increases access to the reproductive health services, promoting the male engagement, and reforming the policies to protect and empower reproductive discipline. So this is my the policy recommendation. Thank you so much.
Thank you, Dr. Salma, for a very informative presentation. And thanks again for keeping the time. I now invite Dr. Lieutenant Retired Farhana for her presentation. And please, you also have the 15 minutes. Or maybe you can take 5 minutes more from other,
That
gaining from other people's time.
reach me. बिस्मिल्लाहिर्रहमानिर्रहीम नामुल नसीरुल्लाह रसूलिल करीम अम्मा बाद मैं फरहाना तबस्सुम पाकिस्तान की पहली एडवांस नर्स प्रैक्टिशनर in 2005 I did the advanced nurse practitioner course till the date for 20 years I am still the only advanced nurse practitioner although my license doesn't carry that because Pakistan Nursing Council that's not approved that yet. I have become the second time advanced nurse practitioner in diabetes clinical care and management. I secured the scholarship at King's College London for doing the clinical care diabetes management and recently I earned that degree. My epigraph on my thesis for front page says, in Pakistan, the future of diabetes care depends on nurses who dare to step forward beyond tradition and lead the way to make a difference. The very good news is that we have beaten India and China. But the very bad news is that we have beaten them to be in third in the world for diabetes prevalence and incidence. And it is surging like fire in Pakistan. And there are equal 33% of the number who are living with diabetes. Equal number is with pre-diabetes, which is not yet diagnosed. And the sustainable goals 3, 4, 5, they all relate to our healthcare. Recently, the Federal Minister of Health, who launched my program of 6-month course, he said, you doctors and nurses, actually you're not doing the healthcare. Stop calling it healthcare. Call it sick care. Because you're taking care of the sick people, you are not doing the primary healthcare. Although it's not 100% correct, people here who are sitting here, they know that how much work they are doing at the primary level. But because of the NCDs and diabetes and women health, reproductive health especially, we still need a lot of work to be done. International Diabetes Federation main theme was access to care, if not now, when? Diabetes care nurses make a difference. That was a theme. Before that, I started the diabetes care. And this is my dear friend from Aga Khan University. She is 1 year junior to me, but she's far ahead of me doing the PhD and postdoctoral. She's in Sharjah University. She says that I have done the difference. I have made the difference. Now you nurses, it's your turn to make a difference. And how we can do it, I will show it. And this video, just 2 minutes only. In Crimean War, and a woman who was looking after the battlefield people realized that more patients are dying with infections instead of battle. And that nurse we know today is Florence Nightingale, whose work in infection control, her diary has become the infection control guidelines. One nurse in Australia, she realized that after polio, certain exercises, if they are done, it benefits the patient. And now we know in the modern world, this nurse invention as a physiotherapy. One nurse in UK, she realized that exposure to sunlight makes children jaundice fade away. And now the phototherapy is part of every neonatal care in the hospitals. Nurses in America, when the outbreak of AIDS happened, they invented things for the isolated patients. They did everything in their power to make the patient to feel comfortable, to feel loved one. One nurse in Liberia, a student nurse, she realized that Ebola virus eruption, how she is going to look after her family. She used the duct tape and dustbin bags to protect herself to transfer the patients. And now we use that PPE that was invented by a student nurse. One nurse looking after the Bell's palsy patients realized it's very difficult to communicate for these patients. So she invented a software, and then she was the one who made these cerebral palsy patients make a difference. So my journey till today here, it was a serious business. All it takes one coach to believe in you that what you want to do is feasible, is applicable, is practical. I was very fortunate to have three mentors. Dr. Shabin Naz Masood, a known gynecologist and diabetologist, especially in Sindh. Whole Pakistan knows Dr. Abdul Basit, the diabetologist, and Hassan Sayyed. In National Idea Bank, he's the one who trained me to present. And out of 3,750 ideas, my idea of empowering community health nurses to deal with diabetes and NCDs in the community won, and I won the prize at fourth position in health from President Albert. Then I secured the Fenn scholarship. It was very expensive. Definitely, I could have not afford doing it. My success is not just overnight happen. It's a journey of years and decades. I had a wonderful team, people who believed in me that what I am saying is feasible, practical, implementable. And this is the paper we recently published, and one of the co-author is sitting here, Dr. Javeria, that the research I have done for this thesis actually became the national survey of first Pakistani nurse-led national survey of diabetes awareness and knowledge and perception of nurses working in Pakistan across 62 cities. 1,220 nurses, graduate nurses responded to this survey. The president of Pakistan Nursing and Midwifery Council, who attended our launch 2 years ago, she said that nurses like you sitting in this hall are actually the change maker, and you will achieve what you are dreaming. My journey as a nurse is very global. I went to 17 places in the world because of the nurses. And this is the background of my study. Diabetes is spreading like fire, and there are 33% of the public living with diabetes. But this burden of NCDs and diabetes, we don't have a single nurse trained for NCD management or diabetes management, not a single nurse practitioner in Pakistan, not a single advanced nurse practitioner in Pakistan except me. So, this is a systemic review of finding gestational diabetes management, that how many women are actually suffering who are with diabetes, or diabetic mother who become a pregnant, or a mother who become a diabetic during the pregnancy. And this is a very, very important study, meta-analysis done, that we need a standardized screening at the community level, at the primary prevention level. My study found out that we have a very limited knowledge at entry level, even graduate level, master's level nurses. They have a very limited knowledge of diabetes. They have a very big lack of structured training in Pakistan. In our curriculum, diabetes as single module does not exist. It goes into the medical and surgical module. In 6 months, you study everything. We have a very minimal exposure to people with diabetes and very limited nurse-led practice environment. I launched the first nurse-led 8 weeks training program at Al Kausar University in Karachi, and it was so successful that 70 graduate nurses and few allied health people persons have joined that course. They wanted to know more about the diabetes so they can look after their families, their communities, their patients. And we need access to that standardized policy. You can see that after that 8 weeks of course, the feedback taken, 39% said they have increased the knowledge. 46% that they have their improvement in the clinical. Although there are only few in-person classes, most of the classes were online. I have given them the assignment, clinical practicum, a research project, and some videos. And still they said there is a significant change in their knowledge, their awareness, their clinical practice. This is the paper which is recently published. So, this is the findings of my study, that we need structured diabetes curricula at advanced nurse practitioner level and nurse practitioner level. I will make it clear. Any graduate nurse can become a nurse practitioner if she does a module on diabetes care and NCDs care. Any nurse with a master's degree can become an advanced nurse practitioner if she has got some modules gone through, especially after the study or during the study. In England, I can do a clinic because I have done this study from England. In England, if they do a 6 month of pharmacology module, then they can prescribe as well. Only thing is that they need to be empowered. We need doctors and nurses and allied health professionals to deal with diabetes and NCDs at the community level. And this is very well aligned with the conference thing which we are attending today. That there are challenges, there are issues, there are difficult situations, but all of us, we have to make a difference. And all of you who are sitting here in this hall definitely are making a difference, because if it was not, they will not be sitting here. They have taken their responsibility, their share, their passion to do something for the public health, primary care, for the population. And it shows that your presence, although if we don't have a lot of audience here, but I count you 50 as not only 50 people. You are 50 institutes here. You are 50 families here. You are 50 cities here sitting. So there is a hope. We can do the reforms. We can bring the reforms in our patient care. And we can bring the strategic improvements as well. मैंने सिर्फ जिंदगी में एक ही बात सीखी है कि हार नहीं माननी, चलते रहना है। 20 साल से पाकिस्तान नर्सिंग एंड मिडवाइफरी काउंसिल ने कहा मैं ना मानू मेरी डिग्री को, जो कि मैंने अपने पैसों से 18 लाख रुपए खर्च करके इन कैंपस जाके यूनिवर्सिटी ऑफ नॉटिंगम में अचीव की थी। लेकिन उनके ना मानने से कोई फर्क पड़ा? मेरे लाइसेंस पे नहीं लिखा हुआ कि मैं एडवांस नर्स प्रैक्टिशनर हूँ, लेकिन मैंने पूरी कोशिश कर ली कि अपने साथ मजीद 50 लोगों को इस लेवल पे ले आई। और मैंने पर्सनली स्कॉलरशिप हासिल की सऊदी अरब से, अपने एक्स एम्प्लॉयर से। सऊदी है वो फैमिली, एंड आई टोल्ड देम in 10 years I left this job in Saudi Arabia. I never asked any favor from them. I just sent a message, I need a scholarship for the nurses in Pakistan. I want to do the diabetes care. I've done a fantastic home care nursing for their VVIP patients. I have established the biggest home care nursing there. So what they did, she just sent me the money to train these nurses at Al Kausar University. शिकवा जरूरत इस शख्स से तो कहीं बेहतर था अपने हिस्से की कोई शम्मा जलाते जाते। हमारे यूथ स्पेशली यही कंप्लेन करते रहती है, फला गवर्नमेंट आई थी तो उसने हमारे प्रोग्राम्स को बंद कर दिया, नवाज शरीफ आए तो उन्होंने इमरान खान की खत्म कर दी, हमारे यहाँ सिंध में भुट्टो अभी तक जिंदा है। लेकिन हम क्या करें, क्या हम छोड़ दें काम करना, जीना, अपनी मेहनत करना। मैंने कल अभी कोई बैठा हो यहाँ पे तो अच्छी बात है, सुन ले कि पॉपुलेशन काउंसिल के कुछ जिम्मेदारों से सवाल किया, आपने इतनी प्यारी है डॉक्यूमेंट बनाई है, इतनी अच्छी है कि कम्युनिटी मिडवाइफ को सल में यूज किया है, लेकिन अनफॉर्चुनेटली मेरी मुझे इस पूरी किताब में किसी भी कम्युनिटी मिडवाइफ का ना नाम नजर आया, ना इंस्ट्रक्टर का नाम नजर आया, ना किसी प्रिंसिपल का नाम नजर आया, ना किसी कम्युनिटी मिडवाइफ की तस्वीर नजर आई। तो फिर किसने की ये ट्रेनिंग कम्युनिटी मिडवाइफ की? अगर किसी डॉक्टर को आके हकीम सिखाएगा तो क्या डॉक्टर डॉक्टर बन सकता है?
You have 3 more minutes.
तो हमें तो ये देखना है कि हम इस सिस्टम को कैसे सही कर सकते हैं, और हमें अपने हिस्से की क्षमा चलानी है, क्योंकि हमने काम करना है और हमने इस डायबिटीज केयर मैनेजमेंट को पूरे मुल्क में इस ट्रेनिंग को इसलिए फैलाना है कि हमारी कौम को जरूरत है, हमारी फैमिली को जरूरत है। थैंक यू सो मच।
Thank you, Dr. Farhana, for a very informative presentation. I just want to, I'm not population council, but I have seen that study on community midwife. It is one of the ethical consideration not to give names of your respondents and not to publish photographs when the respondents say they cannot publish. So that is why not just in population council work, but any research work that we do, we don't never ever mention the name of our respondents, and I think that's a international standard, not a practice which is limited to an organization. So anyway, we have, by the grace of God, have thank you all of the presenters. They were on time. I now turn to Dr. Tosi for his comments and. So Rabia,
Discussion and question answers and then.
okay, over to you.
Thank you. The first paper presented by Tana Al-Sahar, the role and influence of mothers-in-law on young married couples, family planning in Karachi and Hyderabad, Pakistan. This paper, this research fills a critical gap by examining intergenerational power dynamics within households. The paper highlights the reality that family planning decisions in Pakistan are rarely made by the couples alone. They are collective family decisions. And I just want to add, it was a very good paper, and just want to add 2-3 points, like further exploration of how mother-in-law themselves learn and internalize these norms. You can have some ideas on this perspective. More detailed analysis on how young couples negotiate or resist their expectations is needed. And you have used the qualitative and quantitative methods, which is a very good methodology. But I think you must add socioeconomic status when you are taking the perspective of educated and uneducated uh, respondents.
So I have added in the recommendations, and one of the themes highlighted the socio-economical sub-themes.
And also the urban-rural distribution is also needed
Yes.
for the paper. Thank you. The next paper was by Dr. Salma Zahir, examine women's reproductive agency with gender norms and power dynamics in Khyber Pakhtunkhwa, KP. The The paper addresses the critical but underexplored dimensions of reproductive health in KP, how gender norms and power structures shape women's reproductive agency. The paper highlights that reproductive decisions are not only about availability of services, but about social permissions, control, and negotiation within the households. Uh, uh, just 2 3 points to add. More explanation may be added on how women define agency within their own cultural context. What does empowerment look like to the respondents? Consider the distinguishing rural and urban KP dynamics. These are very important. And the possibility of integrating man's voice at they as they shape a women's agency. I need to add linking findings to the provincial FP 2030 commitments and KP Health Department's priorities. Women in KP are not passive, they are navigating layered constraints with remarkable resilience. Our policies and interventions must therefore go beyond service delivery and focus on transforming the gender norms and power dynamics that shape reproductive agency. The next paper by Farhana Tabassum, Transforming Human Capital Through Nurse-Led Diabetes Education, a national initiative to bridge knowledge gaps and improve NCD outcomes in Pakistan. Yes, this is the highest prevalence I think NCD in Pakistan and globally too. This paper is timely because it shifts focus from physician-led care, which is insufficient for the scale of the problem, to nurse-led education, a model with proven success worldwide. Mm, uh, just to add 1 or 2 things, include you must include some details on HbA1c levels and other complications while recommending the nurses education on this diabetes. Um, Access differences between the provinces or facility types, urban, rural. These, I think, for the paper, these background information must be captured, and then we can recommend the program for the nurses. This paper demonstrates the nurse-led diabetes education more than an intervention. It is a national strategy to build human capital, reduce the non-communicable disease burden, and enable patients to truly take charge of their health. Thank you.
Thank you, Raja. Now to chair who will get a question answers and final comments.
Even thank you to all the presenters and this event. Thank you to all the audience who are here now. Let me begin with the question and answer session first before I go on. Mike had.
मेरा बहुत क्विक क्वेश्चन है क्वेश्चन ही कमेंट है बोलते पहली दो जो प्रेजेंटेशंस थे सबसे पहली जो एक्सक्यूज मैंने सुनी थी हमारे फैमिली प्लानिंग डिपार्टमेंट की ये 3M जो है ना वो रिस्पॉन्सिबल है मैन बुल्ला एंड कौन सा था तीसरा मदर इन लॉ ये जो है ना अगर आप ढूंढने जाएंगे तो आपको मिलेगा कोका कोला वाले जो कोका कोला बेचते आते हैं वो नहीं पूछते जाके घरों में कभी आपकी मदर इन लॉ आपको पीने देगी कि नहीं देगी तो मैडम प्लीज हमारा जो प्रॉब्लम है वो वही है और कि हमारी सप्लाई साइड बहुत सारा डिमांड साइड में कोई प्रॉब्लम डिमांड साइड हमेशा ऐसी होगी कुछ लोग यूज करेंगे कुछ आपका काम है कि आप प्रेजेंट दूसरा जो कमेंट है डायबिटीज पे 2007 में when I landed in Saudi Arabia was number 1 in diabetes 30 plus में 29% उनकी prevalence थी diabetes की और वहाँ के लोग जो है ना खजूर और बेकरी और जो है ना एक्सरसाइज का कोई सवाल ही पैदा नहीं होता था और वहाँ जो हाल था ओबेसिटी कितनी ज्यादा 2025 में जाए हर शहर में 100 से ज्यादा जिम्स हैं वॉकिंग ट्रैक्स हैं पार्क्स हैं और ये जो मतलब खजूर वगैरह भी अभी है लेकिन लाइक इट्स लाइक they are controlling the diet they are a nation we are a crowd.
Thank you, sir. Where there is unmet need of 17% or what you have, so it should be. I have a question from Dr. Farah that have you included lifestyle modification in your diabetes program? Because in our university, the students are working on that issue also. So can you throw some light on it?
जी बिल्कुल एक्चुअली वी हैव infiltrated CBT cognitive behavior therapy lifestyle changing क्योंकि एक्चुअली नर्सिस का मोड जो है वो कम्युनिकेशन विद द पेशेंट है तो उसमें लाइफस्टाइल चेंजिंग को हमने एक मॉड्यूल के तौर पर कोर्स में इंट्रोड्यूस कराया है कि आपने किस तरह लाइफस्टाइल की चेंजिंग के ऊपर उसके ऊपर काम करना है फ्रॉम डाइट एक्सरसाइज स्ट्रेस लेवल मेंटल हेल्थ इश्यूज इसको पूरा उसके अंदर लाइफस्टाइल मॉडिफिकेशन में कि आपका स्लीप पैटर्न क्या होना चाहिए आपका मील प्लान कैसा होना चाहिए यानी उसमें एक असाइनमेंट ये भी है मेक अ मील प्लान फॉर अ वीक इंस्टेड ऑफ 3 meals plan for 5 divided meals which are healthy meals और economic point of view से वो ऐसे बनने चाहिए कि हम उनको कोई ऐसी कीटो डाइट उस टाइप की नहीं इंट्रोड्यूस कर रहे हैं हम उनको बताएं जो आपके घर में अवेलेबल है उसको what you are going to use and how you are going to recommend it. So lifestyle changes is actually for the prevention and prevention of complication as well. You see, this is diabetes I consider as maybe you will not agree with me. I consider it not a disease. Actually, it is the outcome of our bad habits. So when we change the bad habits, there will be a change.
And I have one suggestion for the forum that I have been listening to all the talks that we should include these things like mental health, lifestyle modifications, even reproductive health information. It was included in the syllabus long way back. It should be included in 6, 7, 8, 9, 10 students' syllabus so that they are aware of the problem, so they cannot say that nothing has been done for us.
And it's a holistic approach all that.
Didi, I would like to take, carry on with Dr. Fareed's comment and of course, those 3 are a problem in Pakistan, but there are also solutions, not in Pakistan, but elsewhere. And that's elsewhere has been the military, another M, which is the military rule. Okay, and I have done the analysis, so I'm talking in the sense of my own research. Wherever there has been military rule, starting with South Korea, then Thailand, then Bangladesh, Egypt, Tunisia, Turkey. Those were the periods when family planning programs were very successful, if you look at the history. Unfortunately, it didn't happen in Pakistan in the 1970s. And because, of course, there have been other priorities, that Pakistan has other problems. So that could be a solution for us also.
It's an outlier.
Thank you, Dr. Khan. There is a question from there.
Thank you. I am Akhtar, serving economics department here in NES. So first of all, I appreciate all the 3 presenters. I mean, it's really informative and very nice presentations. So my question is basically to first presenter, Dr. Tahira. So the question is that overall family dynamics and things are also evolving and changing over the period of time. And so, I mean, the mother-in-law basically is also losing her power. I mean, it's not like their daughter-in-law is really scared that oh, the mother-in-law will be somewhere around. Like, no, I mean, the things are changing quite, rapidly. So the question is that, do you think there is really mother-in-law who can influence, or is basically the mother of the daughter? I mean, basically who can influence more actually, because the daughters listen to mother more instead of mother-in-law or things like that. So the question is basically that if into a study you can also improve the voice of mothers, so it might have more value. And the second is like as already discussed that it's basically like education and the wealth status of mother-in-law and the things like that. I mean the different dynamics that can add more value. So I mean this basically suggestion, and also I would like to hear from you that the daughters listen more to mothers instead of mother-in-law. So thank you.
So yes, I want to answer that, and as I have heard the comment of Dr. Fareed and Upsa, so I really want to add my my statement as well over that comment. So we see that I work for the operations, and we work in the field on the daily basis. And currently, the platform on which I am working, it's like TCI, the Challenge Initiative, and we are working on the health impact interventions, where I said that we are working on many of the activities. So this was just one phenomena or one behavior that I observed during my field operations, and out of somewhere I decided to deep side usko dig karne ki koshish kari ke what how things come out. And I do believe, I do understand, and I agree with your comment ke supply is always there. हम कभी भी ये नहीं सुनेंगे कि population welfare department के पास अद्वियात खत्म हो गई है. They will never say that, and they will always comment कि if the demand is there, and we will facilitate to each and every district, right? But what's more important here, that behavioral change communication is one thing that we really need to work on. That I have highlighted in my recommendation as well, because behavioral change communication, it's not a moment process कि हमने आज सोच लिया और वो अभी हो गया. It takes years, and even it will take decades. And also it differs from class to class, families to families. बट अनफॉर्चुनेटली हम अर्बन स्लम्स में काम कर रहे हैं. अगर मैं कराची की बात करूं तो 90 से ज्यादा फीसद जो शरह है वो हमारी अर्बन स्लम्स के अंदर रिसाइड कर रही है. And unfortunately we do observe this behavior. Maybe this perspective do not exist in the middle class families or the elite class families. उनके अंदर ये नहीं होगा. And जो मेरा थर्ड थीम था, it has given me the hope कि वो एक पैराडाइम शिफ्ट तो आ रहा है. बिकॉज जिस तरह से हम अब इसको बोलें कि अब मॉडर्नाइज हो रहे हैं या हमारे थॉट्स को एंटरटेन किया जा रहा है, द मदर इन लॉज इवन आर वे मोर एजुकेटेड. शायद हमारी दादियां इतनी तालीम याफ्ता नहीं थी, लेकिन अब हमारी मदर्स हैं, या हम व्हेन वी आर मदर्स, सो वी विल नेवर डू or impose our decisions over my daughter-in-law, right? So things are changing, and it will change eventually, but this is a decade process. Behavioral change communication will take time.
Can you wrap up?
Ji sir, yes sir.
Thank you. Any last question? Oh, go.
अगर चॉइस ऑफ मेथड का बहुत इशू रहता है, आपके पास अवेलेबिलिटी स्टार नहीं होती, तो सर शॉर्टेज एक बहुत बड़ा हमारा हिस्सा पाकिस्तान का ये होता है बड़े सालों से चल रहा है वहाँ. दूसरा ये कि एक चीज याद रखें, देयर इज अ थिन लाइन बिटवीन फियर एंड कंसल्टेशन. आपकी फैमिली में जो है और फियर फैक्टर जो है खत्म होता जा रहा है कि जी वो पता नहीं ये हो जाएगा तो वो हो जाएगा, ये कहानी नहीं है, बहुत कम रहेगी. तो इसलिए इसको ना हमेशा हमें थोड़ा सा सेग्रीगेट करना चाहिए, इसको अलग रखना चाहिए कि ऐसा फियर फैक्टर नहीं है. कंसल्टेशन जारी होती है हर स्टेज में, हर इशू में आपकी जिंदगी में चलती है. ठीक है, इसको जरा जेहन में रखना चाहिए. थैंक यू.
Thank you. Last one. Mind the other.
प्रकाश है नादिर STA से और मेरा क्वेश्चन सेकंड प्रेजेंटर से है। उन्होंने बहुत सारी टेबुलेशन की है, क्रॉस टेबुलेशन भी नहीं, एनालिसिस भी कोई डिटेल नहीं है, लेकिन इम्प्लीकेशन बहुत सारी दे दी है, तो वो कहाँ से ड्राइव हुई है उसकी समझ नहीं आई।
It's my first time studying. It's my first time study, so जिसमें मैं अभी जो है सर्वे कर रही हूँ, ये जनरली थोड़े से रिकमेंडेशन थे, क्योंकि ये कंटिन्यू ये स्टडी एंड आई वांट टू एस्टिमेट सम एप्लीकेशन।
एक्चुअली पॉलिसी इम्प्लीकेशन जब भी आती है,
जी आई नो,
स्टडी से ड्राइव होकर आती हैं, उसी डाटा से ड्राइव होकर आती हैं।
एग्जैक्टली,
जब डाटा से आपने कुछ ड्राइव नहीं किया, कोई टेस्ट नहीं लगाया, कोई मॉडल नहीं लगाया, सिंपली टेबुलेशन, इवन क्रॉस टेबुलेशन भी कहीं नजर नहीं आई।
जी आई नो अबाउट, क्योंकि ये यहाँ पर जो ये जो स्टडी है अब ये कंटिन्यू है ना, क्योंकि जस्ट मैंने डेटा को कलेक्ट किया है, तो इंशाल्लाह आई विल वर्क ऑन, इंशाल्लाह आई विल कॉर्पोरेट योर सजेशन एंड इंशाल्लाह आई विल वर्क ऑन योर सजेशन। जी नहीं, एक्सपेक्टेड रिजल्ट नहीं थे, इट जस्ट आई नो करेक्ट था, लेकिन उस डेटा को अभी जो एनालाइज करके
Yeah. Any question? No, okay, fine. है, all है.
My question is to the Green Star Marketing representative. So what are your marketing strategies to make contraceptives easily accessible to the general public? For example, I was in the US and this is over-the-counter thing. You can go and you can collect and you can purchase very easily. But in Pakistan, it's an extremely private thing to buy and to take this home. So how are you countering this marketing challenge?
Okay, so first of all, social, when you started your question with Green Star Social Marketing. So Green Star Social Marketing is working both with the government and the private sectors, right? We have our own social franchises, and it's more than 200 social franchises all over Pakistan, where they are the outlets are built, and people can go there, purchase there. ठीक है, so that's the different thing कि आप social franchises पे जहाँ पे आपने ये बात करी कि it's a private thing, so we as a TCI we are entirely collaborated with the government entities जिसके अंदर population welfare department, DOH and PPHI के साथ हम काम कर रहे हैं, and we have made sure, जो कि अगर हम 3.5-4 साल पहले देखें जब TCI का प्लेटफॉर्म नहीं आया था, तो हेल्थ डिपार्टमेंट के पास तो कमोडिटीज होती ही नहीं थी। हमने जैसे डॉक्टर समीन से भी सुना कि डिस्ट्रिक्ट लेवल पे वी यूज्ड टू हियर कि भाई ये तो पॉपुलेशन वेलफेयर डिपार्टमेंट का काम है, तो हेल्थ डिपार्टमेंट का काम ही नहीं है। So we have made sure with our capacity building, with our coaching model के health department भी इस चीज पे emphasize करे to keep all the choices of methods, सारी अद्वियात को अपनी प्राइमरी हेल्थ केयर की जितनी डिस्पेंसरीज हैं, सिंध गवर्नमेंट डिस्पेंसरीज हैं, BHUs हैं, MCH सेंटर्स हैं, उसके ऊपर भी रखे, फिर RHCs लेवल पे भी रखे और टर्शरी लेवल पे भी रखे। So this thing I think हम अपने प्लेटफॉर्म के थ्रू इस चीज पे हम काम कर रहे हैं, जिसको हम हाई इम्पैक्ट इंटरवेंशंस के नाम से हम कहते हैं। एंड फॉर द ऑडियंस अवेयरनेस, या हम अपनी कैचमेंट की अवेयरनेस के लिए वी आर कंडक्टिंग हंड्रेड्स ऑफ कैंप्स ऑन मंथली बेसिस, हंड्रेड्स ऑफ सैटेलाइट कैंप्स जो कि फार फ्लंग एरियाज के अंदर होते हैं, और जहां पे FOC फ्री ऑफ कॉस्ट सारी अद्वियात को फराहम किया जाता है to the clients whoever needs it, जहां पे फ्री कंसल्टेशन होती है। So this is वो जो आपने बोला ना मार्केटिंग स्ट्रैटेजी का वर्ड, मैं उसको वोकैबुलरी जो है उसको मैं बोलूंगी वो हाई इम्पैक्ट इंटरवेंशन है, जो कि हम फैमिली हेल्थ डेज या सैटेलाइट कैंप्स के मद में हम अपनी जो कम्युनिटी है, हमारी कैचमेंट, हमारी ऑडियंस है, हम उनको फराहम कर रहे हैं और इंशाल्लाह करते हैं।
शुक्रिया शुक्रिया।
Okay.
Sorry, we have to take a break. Finally, I want to wrap up the discussion. Very encouraging myself from the two and other colleagues. The title of the session was Provincial Reality and Local Responses. What I hear from them are local responses rather than anything on provincial realities. Provincial realities, there are a number of things that you know, and I think each one of you should be acknowledging that too. And your research, coming research, चाहे वो अर्बन रूरल डिस्पैरिटी है अपना आपका सैंपल में वो होना चाहिए कम्युनिकेशन डिस्पैरिटीज हैं न्यू टेक्नोलॉजीज आजकल जो आ रही हैं एआई को कह रहे हैं आप या फिर जो आप सोशल मीडिया है उसका इस्तेमाल है इसी तरह आपकी डेफिनेटली both of you have raised the issue of cultural differences both in the families and also with the couples very important barrier and social communication इसमें एक बहुत important area है that you have pointed out access जो अभी my दोस्त ने जिक्र किया access to family planning has definitely been an issue ever since we have the program चाहे वो health का है operation का है these are all issues that need to be identified 18 amendment ने आगे एक और dimension दे दी है पूरे पाकिस्तान को कि हर province अपने आप एक नए अंदाज से देखता है how do we really see population issues Balochistan sees differently KP sees differently Sindh sees differently so there has to be a national policy कह रहे हैं या national framework कह रहे हैं that should direct all the provinces to implement energy environment accordingly rather than everybody has their own shop to sell. Regarding the family issues, I think in the last 4 decades, what I've seen is breaking of the joint family. The breaking of the joint family has led to lesser role of MI. Okay. Yeah, a very important issue that you should have pointed out, especially in urbanization issue. और आपका रूरल अर्बन का है वो बड़ा important था that you need to identify and also work on it. Your recommendations are very accurate. That means to basically focus on social communication and to basically focus on improving the access to religious leaders of the husbands. And I've seen a number of projects on male involvement, but I think you should also be very important. Swati is one of the most advanced districts in KP. I think it's again a deviant. We should be doing that in Kohat or Hangu or Soya so that we can really see the influence of the culture and also. So I look forward to Kia and that you're doing research. You should be comparing it with more districts so that we should be learning more from the ground and also from the after definitely having a very good experience. Again, I would like to say diabetes is across Pakistan, right? So you need to basically focus on provinces and districts and areas and regions which have higher diabetes. And I think you should also be part of the national surveys like MIX, MICS or PAHS. जिसमें diabetes की measurement होना चाहिए so that you should be able to focus on training nurses on those areas which have higher diabetes. Okay. I thank you very much for all your presence and we conclude this session.
Thank you, Dr. Basir, for your very and my apologies to the two ladies. We had no time for the question and answer. Over to you, Mike.
Thank you so much, Minhaj sir, and I would thanks all the presenters for sharing their insightful research with us. So thank you so much. Now I would like to request Ms. Simi Ashfaq, please come forward and present the shields to our chair, discussant, and moderator. Please. So I request. So I would request Ms. Keeley to present the shield to Dr. Tosif. Dr. Tosif, thank you so much for chairing this session, and your remarks and insights are always very valid and thought provoking. Thank you so much. Now I would request Ms. Rabia Zafar, please. This is a small token of thanks from staff. Thank you so much. And now I would request Minhaj sir, please. Minhaj sir. Thank you so much, Minhaj sir, for moderating and this important session. Thank you so much. And now I would request Dr. Tosif to please present a shield for the team. Thank you. Thank you so much. Thank you. We can have a group photo with all. Rabia, please. And presenters, please come. Let's have a group photo. And now I invite you for the lunch. And I would request all the PAC members, please join us at the lunch, and we are going to have a working general body meeting over the lunch. It's that lunch is only for PAC member. It's the table is set up for all the PAC members. Thank you so much.